Good afternoon, everyone, and welcome to the Mr. Breast Crush course. My name is Alomran. I'm a radiation oncologist at the Comprehensive Cancer Center at King Fahd Medical City, Riyadh, Saudi Arabia, and I will be talking today about the loco-regional radiotherapy after breast conservative surgery. I have nothing to disclose. Here are the outlines of our talk today. So what is the rationale for adjuvant whole breast radiotherapy? Breast conservative surgery and adjuvant radiotherapy is an equivalent alternative to mastectomy for most patients with unifocal disease who desire organ preservation. Radiotherapy following lumpectomy halves the risk of local recurrence and reduces breast cancer mortality. The EBC-TCG meta-analysis was the first study large enough to demonstrate that adjuvant whole breast radiotherapy improved survival. Patients treated with breast conservative surgery with adjuvant radiotherapy showed reduction in local recurrence as shown on the figure on the left and reduction in breast cancer death as shown in the middle figure. The EBC-TCG meta-analysis suggested a 4-to-1 ratio. One breast cancer death was avoided by year 15 for every 4 local recurrences prevented by year 5 and for every 4 any recurrences prevented by year 10. Most patients in this meta-analysis had node-negative disease, and in this group, radiotherapy reduced the 10-year risk of any first recurrences from 31% to 15.6% with an absolute reduction of 15.4%. It also resulted in a reduction of the 15-year risk of a breast cancer death from 20% to 17% with an absolute reduction of 3.3%. So in women with node-negative disease, the annual recurrence rate without radiotherapy was strongly correlated with the age, with the tumor grade, the tumor size, the ER status, especially when women was not receiving tamoxifen and ER-positive disease, and also the extent of surgery. The absolute recurrence reduction produced by radiotherapy also was dependent strongly on these factors. This figure demonstrates the absolute 10-year risk of first recurrences with and without radiotherapy in women with node-negative disease. So the bars shows the 10-year risk in women allocated to breast conservative surgery only, and the dark section shows the 10-year risk in women allocated to breast conservative surgery plus radiotherapy. And the light sections shows the absolute reduction with the addition of radiotherapy. Within each section of the figure, the younger women and those with high-grade disease had substantially larger absolute recurrence risk without radiotherapy and substantially large absolute risk reduction with radiotherapy compared to the older patient and those patients with low-grade disease. Among women who were giving lumpectomy but no radiotherapy, the highest risk and largest absolute reduction with radiotherapy were for women with ER-positive disease not given tamoxifen. However, even when tamoxifen was given, the additional effect of radiotherapy were substantial for the women with high-grade tumors and also younger women with intermediate-grade tumors. So are these results relevant in 2024? So in the past 2 decades, there was substantial improvement in the field of early diagnosis in terms of screening, staging, pathology, the surgical techniques, the systemic therapy, and also the radiotherapy techniques, which have led to an increased local control with higher rates than those observed in older trials. So can we omit adjuvant radiotherapy in patients with low-risk disease? The PRIME study randomized more than 1,000 patients with low-risk disease, including patients who are 65 years and older with smaller tumors measuring up to 3 centimeter, with negative margins and underwent breast conservative surgery and tamoxifen with radiation or no radiotherapy. And the primary endpoint of this study was the ipsilateral breast tumor recurrences. Also, they looked at the regional recurrences, the contralateral breast cancer, distant metastasis, disease-free survival, and overall survival. So the 5-year results of the PRIME2 trial showed that radiotherapy was associated with a lower percentage of patients having local recurrences. 4% without radiotherapy versus 1.3% with the addition of radiotherapy. So the question arises, is 5-year local recurrences of 4% at median follow-up of 5 years is sufficiently low to enough for clinicians to discuss omission of radiotherapy? This is the results after 10 years of follow-up, showing the cumulative incidence of local recurrences reaching up to 9.5% in the no radiotherapy group versus 0.9% in the radiotherapy group, as shown in the figure on the left. In a subgroup analysis of the local recurrences, which was based according to the ER status, the incidence of local recurrence was lower among patients with ER-positive disease. So the 10-year incidence of local recurrence was 8.6% in the no radiotherapy arm versus 1% in the radiotherapy arm. On the other hand, the 10-year incidence risk of recurrence among patients with ER-negative disease in the no radiotherapy group reached up to 19.1%. The other trial is the Cancer and Leukemia Group 9343 trial, which is most similar to the PRIME2 study. So the investigators tested also the omission of adjuvant whole breast radiotherapy in lower risk and older population than the patients outlined or enrolled in the PRIME2 study. So they included women who are 70 years and older, who have clinical T1 N0 disease, tumors measuring up to 2 centimeter, and they received adjuvant radiotherapy plus endocrine therapy versus endocrine therapy alone. As compared with the tamoxifen group, the tamoxifen and radiation patients experience a significantly longer time to loco-regional recurrences. So at 10 years, there were 90% of patients in the tamoxifen group compared to 98% in the tamoxifen plus radiation group were free from loco-regional recurrences. And there was no difference noted among both groups in terms of mastectomy-free survival, disease-free survival, and overall survival. So clinicians and patients must decide whether a 7% absolute risk reduction in local recurrences with the addition of radiotherapy in this low-risk older population continues to justify radiotherapy. However, we have to appreciate that nowadays we have better techniques, hyperfractionated schedules reaching up to 1 week, also the availability of the accelerated partial breast irradiation, which lessen the burden of treatment and also financial toxicity. Lumina trial is a multi-center, single-arm prospective study evaluating the risk of ipsilateral breast tumor recurrences following breast conservative surgery in a group of women with Lumina A breast cancer defined as ER positivity of more than 1%, PR positivity of more than 20%, HER2 negative, and Ki-67 index of less than or equal to 13.25%. So patients would be treated with endocrine therapy, either tamoxifen or aromatase inhibitors for 5 years, and will not be treated with a breast irradiation. So this is the cumulative incidence of breast recurrences at 5 years, which was 2.3%. And of the 10 local recurrences observed, all were invasive. 6 were deemed to be true or marginal recurrences, and 4 were elsewhere recurrences in the ipsilateral breast. The EXPERT trial is an ongoing international clinical trial aimed to enroll more than 1,000 patients. It includes women aged 50 years or older with hormone receptor positive, HER2 negative disease, and it will use genomic test of breast cancer tissue to select women who can safely avoid radiation therapy. And this trial aims to improve personalized use of radiation therapy in early breast cancer. Similarly, the DEBRA trial identifies low-risk patients by using Oncotype DX recurrence score of less than 18 and randomizing patients between radiotherapy plus endocrine therapy versus endocrine therapy alone. So managing axilla in node-negative disease following breast conservative surgery plus sentinel lymph node biopsy. So the understanding of breast cancer biology and its impact on the pattern of recurrences have opened the door to new surgical approaches. Axillary lymph node dissection was long used to identify women with axillary nodal metastasis. It's replaced now with a staging procedure by less morbid the sentinel lymph node dissection. The risk of regional recurrences following negative sentinel lymph node biopsy or dissection is very small and does not warrant axillary lymph node dissection or regional nodal irradiation. Regional nodal irradiation in node-positive breast cancer involves the treatment of supraclavicular lymph nodes, axilla level 3, and internal mammary lymph nodes. Axillary levels can be treated in node-positive disease in patients who undergo sentinel lymph node dissection, and there are several techniques used to treat the internal mammary lymph node using the white tangents, electron fields, IMRT, or VMAT. Axillary lymph node dissection was the standard of care for patients with sentinel lymph node metastasis. The IMRT trial was aimed to assess whether axillary radiotherapy can provide good regional control similar to axillary lymph node dissection but with less toxicity. So IMRT is a phase 3 randomized non-inferiority trial. Patients were randomized to axillary lymph node dissection or axillary radiotherapy before sentinel node biopsy. The axillary radiotherapy included the contents of all 3 axillary levels and the medial part of the supraclavicular fossa. So, IMRT showed no statistical difference was noted in the axillary recurrence occurred over the entire follow-up period. In comparison, the non-randomized patients with negative sentinel lymph node biopsy had also similar axillary recurrence rates of 0.8%. There was no difference in terms of disease-free survival or overall survival noted. So what we learned from both the ACAZOG Z11 and IMRT trials, so patients with T1, 2, and occult low-volume axillary disease have a low risk of regional recurrences, and the type of axillary treatment have no impact on overall survival. However, it can affect the outcomes in terms of treatment-related morbidity. The IMRT study confirms improved outcomes with radiation over axillary dissection, but still common practice to complete the axillary dissection if more than 2 nodes are positive despite the absence of data to support this practice. Finding of these trials should not be extrapolated to patients not meeting the eligibility criteria. The MA20 is a phase 3 randomized trial testing the impact of regional nodal irradiation on the outcome of a high-risk patients. So it's a unique study because it included patients with 1 to 3 nodal macrometastasis They were all treated with modern chemotherapy and endocrine therapy. They were treated with modern radiotherapy to all nodal group, including the internal memory, supraclavicular fossa, and high axilla, with avoidance of excessive cardiac and lung irradiation. So this figure shows the 10-year Kaplan-Meier curves of survival. Panel A on the top left shows there was no difference in terms of overall survival between the two treatment groups, and panel B on the top right showed that the addition of regional nodal irradiation resulted in improvement in disease-free survival. Panel C and D on the bottom shows also improvement in terms of the isolated loco-regional disease-free survival and distant disease-free survival in patients who received regional nodal irradiation. The EMRTC is a phase 3 randomized trial, included similar group of patients with early stage node positive and high risk node negative disease with central or medial locations. Patients were randomized to whole breast radiotherapy or chest wall irradiation alone versus loco-regional radiation, including internal mammary and medial supraclavicular fossa irradiation. So, as shown in the table, regional nodal irradiation improved disease-free survival and breast cancer mortality with minimal increase in pulmonary fibrosis. There was no difference in terms of overall survival among the two groups, and no difference in terms of cardiac toxicity. So what are the implications of both MA20 and ERTC trials? Regional nodal irradiation improves disease-free survival, breast cancer mortality with no effect on overall survival. The results of MA20 and ERTC suggest that all women with node-positive disease to be offered regional nodal irradiation, provided they are made aware of the associated toxicity. And it also supports the importance role of regional radiotherapy in selected patients. And you will have more elaboration on the role of regional nodal irradiation with Dr. Albish later this afternoon. So radiotherapy after primary surgery for early breast cancer has historically been delivered in 5 daily doses per week over at least 5 weeks. But randomized phase 3 clinical trial done in Canada, the UK, later on in China and Denmark have confirmed the safety and efficacy of hypofractionated schedules. At least 5 randomized trials with more than 8,000 patients and 10-year follow-up have demonstrated similar outcomes between conventionally fractionated radiotherapy with respect to the loco-regional recurrences, the overall survival, also cosmesis and toxicity. So following these data, 3-week schedules have replaced the traditional regimens in many countries over the past decade for most, if not all, patients prescribed local or loco-regional radiation after breast conservative surgery or mastectomy. But can we reduce this further? The Fast Forward trial was conducted to assess if 1-week treatment can be as effective as 3 weeks of radiotherapy. And this trial was published in early 2020 and have been utilized extensively during the COVID crisis. So the study included more than 4,000 patients with early stage of breast cancer, and patients were randomized to 40 gray in 15 fractions over 3 weeks, or 27 gray in 5 fractions over 1 week, or 26 gray in 5 fractions over 1 week. The primary endpoint was ipsilateral breast tumor relapse. The figure on the left shows there was no difference in the incidence of breast tumor relapse at 5 years among the 3 groups. Also, there was no difference in terms of loco-regional relapse, distant relapse, disease-free survival, or overall survival. However, there was a significantly increased risk of moderate or marked effect in breast or chest wall for the 27 gray group compared with the 40 gray, and no significant difference between the 26 gray group and the 40 gray group. So the fast-forward results confirmed that 26 degree and 5 fraction is as effective and safe as an international standard 15 fraction regimen for breast cancer. And the 1 week schedule has a major benefit in terms of convenience and costs for the patients and also for health services globally. The typical workflow in the radiotherapy oncology department include, as you know, the clinic visit, CT simulation, contouring, planning, and treatment delivery. And this process may take around 2 to 3 weeks depending on the patient workload within the department. CT simulation involved the positioning of the breast cancer patient, that is commonly involved lying supine on a breastboard, backlock, with arms abducted and shoulders are externally rotated. When using the breastboard, the optimal angle for the planning is determined during the CT simulation, considering the patient's physical build and also the treatment technique to be used. The optimal angle for the planning purposes is when the sternum is horizontal parallel to the treatment couch. And the benefit or the goal of this angulation is to reduce the lung and heart exposure within the tangents, and also decrease skin fold both inframammary and also between the breast and the axilla. The head will be placed in neutral position or can be turned to the contralateral sides when we consider nodal irradiation. The chin can be lifted. What we use in our center, we use chin mask to support the jaw in a fixed position and ensure reproducibility. The CT should be obtained within an image thickness of less than 5 millimeter. So the pictures shows the patient positioning and marking for CT simulation in the supine and the prone positions. The radiopaque markers must be placed on the external landmarks at the acquisition of the CT scan to facilitate contouring. And these markers should identify the lumpectomy incision, the outline of the palpable breast at least from the 2 o'clock to the 10 o'clock position, and the superior border of the breast at the level of the 12 o'clock position on palpation. And additional markers can be placed as needed. There are some challenges that we face during CT simulation for patients who have difficulty raising their arms and those with pendulous breast. So for patients who have difficulty raising their arms, so we give them a rest and we don't proceed with the simulation. We give them some education, refer them to physiotherapy, assess them in a week time or on a weekly basis to see how the improvement in the arm movement and try to repeat the CT simulation. Now you may face some patients who might have, let's say, a fracture or some spasticity that may affect the positioning of the arm, which can be permanent, but this still will not prevent the patient from receiving radiotherapy. So we have to come up with a position that can be reproducible and aids in the treatment planning. The other challenge is having a large pendulous breast. In such cases, we might utilize the use of breast bras or the thermoplastic mask that can support the breast in a good position for the patient to have hair treatment to minimize the side effects. So, and I encourage you to attend the CT simulation when you have challenging cases, when you assess the patients in your. Several contouring guidelines have been suggested for target volume delineation in early breast cancer. The RTOG published a contouring atlas in 2009 and were based on the use of bony and muscular landmarks to include tissues that would have been treated with traditional treatment field design. So for breast-only treatment, the cranial border of the breast include the clinical reference at the time of the CT plus the second rib insertion. The caudal border is the clinical reference and the loss of CT apparent breast tissue. The lateral border include the clinical reference and mid-axillary line, typically excluding the latissimus dorsi muscles. The medial border is the sternal rib junction, and the posterior border exclude the chest wall, the ribs, and also the pectoralis muscle. So this figures shows the breast contouring following lumpectomy for breast-only treatment on the left versus breast and chest wall treatment on the right. And those were included in patients who have stage 2, stage 3 disease, who receive new adjuvant therapy and lumpectomy, or we think they have sufficient risk to develop chest wall recurrences or would need post-mastectomy radiation. And as you can see on the arrow indicates, the posterior border of the breast contours include the pectoralis muscle, the chest wall, and the ribs, unlike treating only the breast only treatment. For regional nodal contours, the supraclavicular nodal volume starts caudal to the cricoid cartilage to the level of the junction of the brachiocephalic and the axillary vessels and the level of the clavicular head. Anteriorly, it will be bounded by the sternocleidomastoid muscle, and posteriorly, anterior aspect of the scalenus muscle, and medially excluding the trachea and the thyroid. The level 1 will, the one indicated in the yellow, will start when the axillary vessels cross the lateral edge of the pectoralis minor and ends when the pectoralis major muscle insert into the rib. Posteriorly, it's bounded by the anterior surface of the subscapularis muscles and the medial border of the latissimus dorsi muscle. And for axilla level 2, it will start when the, so this shown in the pink, it will start when the axillary vessel across the medial edge of the pectoralis minor and ends caudally when the axillary vessel across the lateral edge of the pectoralis minor muscle, and anteriorly it's bounded by the anterior surface of the pectoralis minor muscle. The axilla level 3 starts when the pectoralis minor muscle inserts into the coracoid process here, and ends when the axillary vessels cross the medial edge of the pectoralis minor muscles. The internal mammary contours, as shown here in the green, encompass the internal mammary vessels in the first 3 intercostal spaces. The Ester Consensus Contouring Guideline was published in 2015, and the concept of the Ester guidelines was different than the RTOG, defining the nodal target based on the vascular anatomy rather than the bony landmarks. So the breast target volume include the total glandular breast tissue as determined during the CT simulation. The medial border extend to the ipsilateral edge of the sternal bone but we can use the branches of the internal thoracic artery, and where it can identify the medial aspect of the breast contour, as you can see here in this point at the arrowhead. Also, in terms of like the lateral border of the breast tissue, it is bounded posteriorly by the lateral thoracic artery from which the breast is supplied. The major difference in nodal contouring between the ERTC and RTG atlas includes the following. The axilla level 2, as shown in the red contours, this one here. This volume is located posterior to the pectoralis minor muscle. And then we have the interpectoral lymph nodes shown in cyan contours. So this is the rotor lymph nodes, and it's not included in the RTOG atlas, and are located anterior to the pectoralis minor muscle and posterior to the pectoralis major muscle. Axilla level 3 is shown in the dark blue, and this called the infraclavicular volume, and is located medially to the pectoralis minor muscle and CTVN level 2, and the medial limit is the clavicle and the junction between the subclavian and the internal jugular vein. The cranial border follows also the CTVN level 2 and then connects to the caudal limit of the lymph node level 4, which is the supraclavicular volume. So the supraclavicular volume, or lymph node level 4, will encompass the internal jugular vein medially and will exclude the common carotid artery and also the thyroid gland, as you can see here. And the caudal edge will be connected to the internal mammary lymph node volumes. So the CTVN of the internal mammary encompasses the internal mammary vessels with 5 mm margin. A few small current studies showed that both contouring guidelines, the RTOG and the ERTC, don't cover the entire lymphatic drainage system because a significant part of the lymph node recurrences occur outside the recommended borders. Plus, also the existing data have limited validity because of the manual mapping of the lymph nodes and the use of less sensitive imaging like CT scan. So the authors of this study aim to localize and map a large number of loco-regional lymph nodes metastases using FDG PET-CT scan datasets in 235 patients with more than 500 lymph nodes, resulting in a comprehensive lymph node atlas. So here you can see the color-coded lymph node incidence atlas compared with the ISTRO and the RTOG CTV guidelines. The majority of the detected lymph node volume is covered by both contouring guidelines. However, the ISTRO CTV and RTOG CTV don't provide coverage of the whole loco-regional lymphatic drainage. Relevant difference between the two subgroups, the primary versus recurrent breast cancer, was observed in all lymph node levels except for the supraclavicular lymph node level, and both primary and recurrent lymph node metastases exceeded the cranial border of level 1 to 4 and the lateral border of level 1, as you can see in this figure. There were a total of 107 lymph node metastases detected in patients with primary breast cancer, with no distant metastasis, and the majority of these lymph nodes were located in the axillary levels 1 to 3. And compared to this, the lymph node distribution in patients with recurrent disease or distant metastasis shifted in favor of the supraclavicular and internal mammary regions. So for patients with recurrent breast cancer, there were up to 20% of the lymph nodes located in the supraclavicular region, which is really high compared with patients who have a primary breast cancer. So evaluating the RTOG and ISTRO guidelines for each subgroup, there were a total of 12.4% lymph node occurred outside the ERTC atlas versus 9.4% of the lymph nodes outside the RTOG atlas in patients at the time of primary breast cancer diagnosis. And the data revealed an increased occurrence of lymph nodes outside the RTOG CTV and ISTRO CTV for recurrent breast cancer compared to primary diagnosis. And this may be as a result of the altered lymphatic drainage as a result of the surgical or the systemic therapy or the radiation therapy received. The most recent atlas by the NRG was developed in 2016 following concerns regarding loco-regional recurrences at the edge of the volume. It's called the RADComp Atlas, and it was developed for a phase 3 clinical trial comparing the use of photons and protons to treat breast cancer when regional nodal irradiation is required. One of the main differences the inclusion of the posterior neck volume, which is contoured here in the light blue, that is not included in either the ISTRO or the RTOG guidelines. So the RAD-comp follows the ISTRO by including the perivascular fat space when contouring the internal mammary lymph nodes, as you can see here, unlike the RTOG atlas, which just encompasses the internal mammary vessels. This is the table shows the hyperfractionation dose constraints obtained from the RTOG 1005 protocol. The breast PTV eval, the V95% should be more than 95%, and the Dmax should be limited to less than 115%. The V16 of the lung less than 15%, the V8 gray less than 35%, and the V4 gray less than 50%. The D mean of the heart less than 3.2 gray, acceptable up to 4 gray. The V16 less than 5% for left-sided breast cancer and 0% for right-sided cancers. The V8 should be less than 30% for left sides and less than 10% for the right side, and the Dmax of the contralateral breast should be limited to less than 3.3 gray. This table shows the fast forward dose constraints. The breast PTV eval, the V95% more than 95%, and the V105% should be less than 5% of the breast volume. And the volume receiving more than 107% of the dose should be less than 2%. And the Dmax should be limited to 110%. The V8 gray should be less than 15%, and the V1.5 gray of the heart less than 30%, and the V7 gray less than 5%. So switching to treatment planning, standard field consists of medial and lateral tangential beam designed to encompass the entire ipsilateral breast. And attention is given to adequate coverage of the tumor bed and clearance of the breast tissue. You can see here the BMI view of the tangent showing the breast tissue. Here you can see the axial image showing the medial and lateral tangents, and this placement of the fields on the skin rendering. Forward IMRT planning, it's a very simplified form of IMRT with only a few segments per field, whose shape and weight are optimized by the planners in order to achieve the best homogeneity to the target. So first, 3-dose distribution will be calculated for equally weighted open fields without any beam modifiers, and then isodose surfaces within the breast projected in the beam eye view with either the medial or the lateral field, and these isodose surfaces ranges from 100 to 120%. Then the MLC segments are designed to block these surfaces, allowing the customization of tissue compensation. The segment weights are optimally adjusted so that the hot spots are minimized without compromising the adequate coverage to the breast tissue. This is a multi-center randomized trial by Prof. Pinol, which has proven this technique to be effective in reducing acute radiation dermatitis and also in improving the quality of the life compared to standard methods. Breast IMRT significantly improved the dose distribution compared with the standard radiation, including the clinically significant maximum, the sagittal dose gradient, and removed the hot spots in the inframammary fold. And this translated into a lower proportion of patients experiencing moist desquamation during or up to 6 weeks after their radiation treatment, 31.2% with IMRT compared to 47.8% with the standard treatment, as shown here in the table. This is also another trial from Korea to investigate the safety and efficacy of IMRT for early breast cancer compared with a 3D conformal radiotherapy. It's a prospective and randomized trial that enrolled patients between 2015 and 2018. Included more than 600 patients with early stage node-negative breast cancer, and were assigned into IMRT and 3D conformal radiation. The primary endpoint was a 3-year Loco-regional recurrence-free survival, and the secondary endpoints included overall survival, acute toxicity, the target coverage index, and also radiation dose to organ at risk. So there was no significant difference in terms of lymphedema or radiation pneumonitis between the two arms. Grade 2 or higher radiation dermatitis occurred less frequent in the IMRT compared to the 3D conformal radiation. Also, IMRT significantly lowered the irradiation doses to the ipsilateral lung, and the target coverage was significantly improved with the IMRT as compared to 3D conformal radiation. There was a significant difference in the mean hard dose between the IMRT and the 3D conformal only for the left-sided breast cancer patient, but not for the right-sided breast cancer patient. The multi-beam IMRT employs 9 to 11 beams equally spaced through 190 to 220 degree sector angle around the target volume. resulting in a conformal coverage to the target and sparing organ at risk. And the advantage of using multiple beams in a fan shape around the target, its ability to produce a conformal coverage to the target while sparing the high doses around the critical organs like the heart and the lung in breast radiotherapy. There is a significant reduction in volumes of the heart and the ipsilateral lung receiving 30 gray or more that's shown compared to standard 3D conformal technique. However, the disadvantages of the IMRT is the low dose bath, as you can see here in this axial images, which we don't see usually in the 3D conformal radiation, and also it results in a longer treatment time and more monitor units. VMAT is a type of IMRT where the radiation delivery is much faster and requires fewer monitor units, making it more convenient modality for radiotherapy planning and delivery. And it's delivered continuously over an arc range with VMAT. Disadvantages similar to the IMRT, it has also the low dose bath, as you can see here compared to the 3D conformal radiation. This is just an illustration of different treatment planning techniques. The field-in-field, forward IMRT, IMRT, VMAT, hybrid IMRT, and hybrid VMAT, which combine the use of 3D conformal along with the VMAT technique. What's the impact of the respiratory maneuvers on the cardiac volume within the left breast radiation portals? So this was the first study that assessed the impact of respiratory maneuvers on the cardiac volume within the left breast radiation portals. So on the left, this is an example that shows the decrease in the cardiac involvement with breath holding at deep inspiration relative to the baseline end-tidal volume at the same anatomic level. On the right, shown the change in cardiac volume versus the end-tidal volume. So the inspiration substantially and consistently reduces the volume of the heart within the radiation portals, whereas the expirations lead to an increase in cardiac involvement. And the authors concluded that the use of inspiratory maneuvers significantly decreases the cardiac volume within the radiation portals. And they suggested that the implementation of a simple inspiratory breath holding during delivery of radiation therapy may preserve radiation dosage to the breast while reducing the cardiac involvement. In modern radiotherapy, a range of options exist in addition to 3D conformal radiation to decrease the heart dose for breast and also other cancers. And this includes the prone positioning in breast radiotherapy, IMRT, the use of VMAT, respiratory management including deep inspiration breath hold, and also proton therapy. So what is deep inspiration breath hold? In DIBH, a patient takes a deep breath and then holds it for a period of time during simulation and also during delivery of radiation. DIBH results in a significant anatomic changes. The motion is minimized. The lungs are inflated and push the heart downwards and posteriorly away from the target volume. Currently, there are two commonly used methods for DIBH. The spirometry-based active breathing coordinator, the ABC system, and the video-based real-time position management, the RPM system. So the ABC device is a mouthpiece attached to a spirometer, Once the patient has reached the required threshold, the pinch valve in the spirometer remotely close, preventing the patient from exhaling or inhaling outside the required threshold. On the right is a demonstration of the ABC setup. The RPM system incorporates an infrared camera that detects the marker box placed on the patient and calculates the position and movement of the thorax. During the DIBH, the patient must voluntarily breathe to the required threshold, and the system is linked to the linear accelerator and will automatically trigger the beam hold if the patient's breathing falls outside of the acceptable threshold. So here is the demonstration of the RPM setup with the marker box positioned on the xiphoid process, and the visual feedback is provided using the modified video goggles. Bartlett and his team compared the two systems in a randomized crossover study of the left breast cancer patients, and they concluded that the setup, reproducibility, and normal tissue sparing were comparable between the both techniques. However, patients found the voluntary DIBH technique more comfortable and less claustrophobic compared to the ABC technique, and it was preferred by radiographers, takes less time to deliver, and also is cheaper than the ABC DIBH system. Many dosimetric comparisons have noted the benefit of DIBH, especially with regards to the heart dose parameters, and this table includes the study examining free breathing versus DIBH for breast cancer patients. The DIBH has been associated with significant improvement in both the mean heart doses and also the mean LAD doses, with respective decreases of 25 to 67% and 20 to 73% when comparing the same patients planned with free breathing compared to DIBH. Most of the DIBH studies shown in the previous table have focused on reductions in the mean dose to the entire heart without quantifying the benefits of dose reduction to the individual cardiac and coronary artery segments. And the aim of this study by Song was to investigate the dose reductions from DIBH in individual cardiac segments in patients receiving left breast radiotherapy. So this is a retrospective dosimetric analysis of patients with left-sided breast cancer who underwent a breast conservative surgery and adjuvant radiation using DIBH. So the CT shows the left lung with the DIBH displaces the heart and coronary arteries, especially the apical left ventricle and the distal LAD segments, away from the radiation fields, resulting in reducing doses to the apical left ventricle and distal LAD, while the other segments remain largely unaffected. For the majority of patients, the mean dose to the LAD was smaller with the DIBH compared with the free breathing, so 5.8 gray compared to 14.6 gray, except in 4 patients. The Save Heart study involved 89 patients with left-sided breast cancer. The authors estimated the individual radiation-induced risk for death of ischemic heart disease under free breathing and DIBH based on expected survival and individual ischemic heart disease risk factors and the relative radiation-induced risk. The mean expected years of life lost due to radiation-induced ischemic heart disease mortality were 0.11 years in free breathing and 0.07 years in the DIBH. The DIBH have led to a more pronounced reduction in the years of life lost in patients with high baseline risk with favorable prognosis and patients with high mean heart doses in free breathing. 0.09 years for doses more than 3 gray versus 0.02 years for doses less than 1.5 gray. And what they concluded that the DIBH technique should be offered to all patients with left-sided breast cancer. However, the highest benefits are expected for patients with favorable prognosis with a high mean heart dose and a high baseline ischemic heart risk independent of their age. And this is an example of a real treatment plan where the IBH was used in planning and treatment. On the left shown the 95% dose color wash and CT planning imaging performed during the IBH as compared to deep free breathing. And this is a short video showing the difference between the free breathing and the IBH, and I hope it works. Okay. So with that, I would like to conclude my presentation and thank you for your attendance, and wish you a nice afternoon with the upcoming lectures. Thank you.